work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
doing so ultimately builds
A healthier, safer world for everyone.
We are the Kirby Institute.
Afternoon, everyone, and welcome to the Kirby Institute's World Hepatitis Day special event, Progress Towards Hepatitis C Elimination, Insights from Modelling. My name is Greg Dorr. I'm head of the Viral Hepatitis Clinical Research Program. I'd like to begin by acknowledging the traditional custodians of the land on which we gather today. For myself and others here on Bidjigal land, and pay my respects to their elders, past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples joining us today. A few housekeeping things. The format for the webinar will be start off with a presentation from Natasha Martin, followed by Q&A. You can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. Okay. World Hepatitis Day takes place every year on the 28th of July. We're a few days early, but the 28th of July is actually the birth date for Dr. Barack Bloomberg, who was the discoverer of hepatitis B. Bringing the world together under a single theme to raise awareness of the global burden of viral hepatitis and to influence real change. In 2023, the theme is We're Not Waiting. Our speaker today, we're very, very happy to have Professor Natasha Martin present. Natasha is an infectious disease economic modeller who develops dynamic transmission models to evaluate the impact of cost effectiveness of public health interventions. She's a professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego, and holds an honorary senior lecturer position at the University of Bristol. The modelling work has informed the WHO Global Health Sector Strategy on viral hepatitis and several country and local elimination plans. She's also a wonderful collaborator with the Kirby Institute and over many years a close colleague and friend. Thanks again, Natasha, for the opportunity to hear your insights today.
Thanks, Greg, and thank you so much to everybody for attending. It's really an honor to be here today. So I will see if I can succeed. Okay, hopefully you can see my slides. So yeah, thanks again for having me. I'm really pleased to be able to speak today. My talk, because I'm an infectious disease modeler, will be talking about hepatitis C elimination and some of the insights that we are getting from modeling using a few different case studies, which I hope you'll find interesting today. So I do want to start with acknowledgements. This is highly collaborative work that's done across a number of universities. So I am presenting work where we've had a number of contributors at UCSD in particular, Jessica Chima and Lara Marquez, the students and postdocs who have led some of the modeling work that I've talked about today. As Greg mentioned, we have a long-standing collaboration with the Kirby Institute and the University of New South Wales, Jason Grebley, Greg Dorr, Andrew Lloyd, and Lisa Mayer, and among others. And I'll be highlighting some of that work today. And also mentioned, I have a joint appointment at the University of Bristol and have a lot of this work also is done highly collaboratively with them, in particular, Peter Rickman, Matt Hickman, Jack Stone, and Aaron Lim. I'll also be talking a little bit about some of the work that we've done in the US-Mexico border region, so have some collaborators there. And finally, just to acknowledge our funders and to say that some of this work has been funded by Gilead, as well as NIH, CDC, and Australian NHMRC funding. Okay, so with that out of the way, today my talk will focus on the WHO hepatitis C elimination targets. And in particular, what I'd like to talk about today are the two targets, the target to reduce hepatitis C incidence by 80% and reduce hepatitis C related mortality by 65% in 2030 compared to a 2015 baseline. And today my talk will really focus on that incidence reduction target and thinking about what we need to scale up in terms of reducing hepatitis C incidence and where we are in progress in terms of reducing incidence across different settings. So I'll talk about three pieces of work that we've done today, showing you a little bit both on modeling as well as the data that we have looking at hepatitis C incidence elimination, our progress towards that goal. First, I'll start with the United States. Really, in many ways, the furthest behind, but some exciting new initiatives and modeling work that we're doing to assess what we need in order to achieve the elimination goals. Then I'll talk briefly about Mexico and the modeling work that we've done, predicting what treatment would be needed to achieve elimination in one particular setting in Mexico, and assessing whether or not we are attaining those treatment targets. And then I'll talk about the work that we're doing that's ongoing in Australia, where we're at a further stage using modeling to really evaluate progress towards hepatitis C elimination. And then I'll close with a brief discussion about barriers and opportunities. So starting first with the US, not because we're the best, but actually really in many ways the opposite. We're a little bit late to the party. Hepatitis C is a public health crisis in the United States, as well as many places worldwide. The concerning thing about the hepatitis C situation in the US, as you can see here on the left, is that reports of acute hepatitis C have increased dramatically, over 400% between 2010 and 2020. And those rates are highest among 20 to 39-year-olds, indicating that we have, ongoing hepatitis C transmission among this young age group. When this slide was developed, it was estimated that there are about 2.4 to 3 million people living with hepatitis C in the United States. There's ongoing work that I'm aware about that is potentially revising that estimate quite substantially upwards. So there's a large burden of infection that has been untreated, and about 40% of people with hepatitis C are unaware of their infection in the United States. So a significant proportion, both unaware as well as untreated. In the background of this increasing incidence and high burden of infection, we also see a concerning increase in the population of people who inject drugs in the United States. So this is a recent estimate that just came out this year, that the PWID population size in the US is about 3.7 million individuals in 2018. Now that estimate was 5 times higher than the most recent estimate in 2011, but those two estimates were generated using different methods. So using sort of comparable methods to the new population size estimate, there's probably between a 3 and a 5-fold increase in the PWID population size from 2011 to 2018. So really substantial increase in population size. And I think we're seeing that in terms of increasing in acute infections, but we're also seeing that in terms of increasing number of fatal overdoses. Over 100,000 people died of a fatal overdose last year in the United States, and that number has increased year on year. So a very substantial concerns in terms of this escalating sort of syndemics of injection drug use, hepatitis C, and opioid overdose. Promisingly, finally, just in March of this year, the White House budget included a plan to eliminate hepatitis C. Well, really, it was just a budgetary allocation that was proposed to spend about $13 billion on both treatment, testing, and education for hepatitis C. So this was really exciting news that could catalyze a lot of activity in this area in terms of hepatitis C elimination. Prior to this point in time, although there were state and local initiatives for hepatitis C elimination, there has not been a national plan. And so now we see a commitment towards funding this. There were several elements of that plan, including incorporating and accelerating progress towards point-of-care diagnostics, and I'll get back to that in a moment. But one of the key cornerstones of this hepatitis C budgetary allocation is that they would expand hepatitis C treatment using what they reference, the model that was used in Louisiana, which was really a subscription model. They call it the Netflix model. It's very American to sort of reference Louisiana as paving the way, because obviously this happened several years earlier in Australia. But okay, so the state of Louisiana for a few years has launched, since 2019, launched this subscription model for two specific populations. So for corrections populations, as well as Medicaid populations. Medicaid is the insurance for indigent people in the United States. So across sort of Medicaid and corrections, that will cover the quite a large, if not the vast majority of need for treatment for people, for example, for people who inject drugs. It doesn't cover everyone, but it would go a long way to providing access to treatment for people, I think, with substantial ongoing risk. So in the state of Louisiana, since 2019, they've had this hepatitis C subscription model that was negotiated between the Louisiana Health Department and a subsidiary of Gilead Sciences. There was a 5-year agreement where they paid a fixed amount and got unlimited access to drug in these two populations. One of the impetus for increasing access, particularly in corrections, is that it was known that there's a high burden of infection among individuals who are in correctional settings, both prisons and jails, and yet very, very few of them were treated. This is data that's a little bit old. It's from 2016. It's from 2015, looking at the proportion of inmates with known hepatitis C who had received any treatment. And you can see here that the darkest states here are between 2% and 6% of the inmates that had received any treatment, and basically going down below there. So, in the vast majority of the US, in 2015, virtually, less than 1% of people in correction settings had received hepatitis C treatment, despite a substantial burden in that setting. So there's ongoing work by Risha Irving and her team at Johns Hopkins to evaluate the impact of this hepatitis C elimination program, both documenting the burden of hepatitis C in Louisiana prisons and jails. And then we're working on some associated modeling work to look at the potential impact of scaling up treatment in those settings, as well as in the community on ongoing transmission. And that work is ongoing, so I can't present it today, but stay tuned. I'll be excited to present it to you when we're ready with it. But what we have done now is work on a national hepatitis C elimination model, trying to understand, using modeling, how these changing demographics that I mentioned in terms of increasing PWID population size and increasing hepatitis C incidence will likely translate into future trends in terms of number of new hepatitis C infections, and what level of intervention scale-up is required to achieve elimination. And so this is work that was led by my student, Jessica Anchima, and he developed a dynamic general population, age, and risk stratified model of hepatitis C transmission and disease progression. So this incorporates transmission among PWID, as well as aging, out and cessation of drug use, and disease progression and treatment. And so we're able to use this model to look both at hepatitis C incidence as well as hepatitis C related mortality, although I'll focus really on the hepatitis C incidence part of that today. The model is calibrated to data on population demography in the United States, as well as estimated numbers with chronic hepatitis C, both in 2014, as well as our revised estimate, the proportion who are diagnosed, the number of treatments that we've had historically, as well as this increasing PWID population size that I mentioned, with about a 3-fold increase from 2011 to 2018. And we also calibrate to data on the relative increase in new infections over time. As I showed you earlier, acute infections have been increasing over time. And so these are outcomes from the model, looking at projecting the number of new hepatitis C infections per year from 2015 all the way out to 2030. And you can see the model projection is that blue line with the gray shading, the 95% confidence interval of the projections. That red data point is an estimation by the CDC of the number of new hepatitis C infections. That is a very, very uncertain estimate. It's based on the number of new acute diagnoses and a ratio multiplier of the estimate of how many cases go undiagnosed. So as you can see, there's wide uncertainty in that acute infection, the new hepatitis C infection estimate. But regardless, what you can see over time with the model projection is that the model is predicting a steady increase in new hepatitis C infections per year, with a median of about 60 to 70,000 new hepatitis C infections in 2015, increasing with our status quo diagnosis and treatment rates to over 150,000 estimated new hepatitis C infections by 2030. That is with our current diagnosis and treatment rates currently. Now, the modeling says that even in a wildly optimistic scenario where in 2023 we start treating everybody who's diagnosed in the United States, what you can see is that it's predicting a relatively modest impact on reducing the number of new hepatitis C infections per year. And that's this green dotted line. So it does reduce it, but because it's the substantial proportion of individuals who are undiagnosed and the increasing incidence and increasing population at risk of acquiring hepatitis C infection with our expanding population size, treating everybody who's diagnosed would not even stabilize hepatitis C incidence from where we are today in 2023. And so in order to reduce hepatitis C incidence to the levels required to achieve hepatitis C elimination, we really need to be doing much, much more to address this ongoing epidemic. Now, two critical elements of that, and there are many, but the two that I'll point out are the need to increase diagnosis. Part of this is a diagnosis problem. I'm not sure if I mentioned, but I'll say it now. RNA point of care tests are not yet available in the United States. That's a huge barrier. It is one of the cornerstones of the White House elimination budget allocation, is to provide funding in order to accelerate that pipeline and make these point of care tests approved and more widely available. That will, I think, go a long way to facilitating this. But we also need a lot of expansion in terms of treatment and location of treatment, modality of treatment, getting treatment out into the community, as well as increases in harm reduction. I'm sure everybody here knows, but just to reiterate that we have very effective harm reduction measures that are effective in primary prevention for hepatitis C. So there's now sort of a systematic review data that has analyzed the effect of opioid agonist therapy and needle and syringe programs on hepatitis C incidence. These analyses have shown that OAT, if delivered at sufficient dose, is effective at preventing both primary and reinfection for hepatitis C. There's more tentative evidence to support the effectiveness of needle and syringe programs and prevention of hepatitis C transmission among people who inject drugs, but quite good evidence that in combination, opioid agonist therapy and high coverage needle and syringe programs, so that's receiving one or more syringe for every injection, are highly effective in preventing hepatitis C transmission. Estimates that receiving adequate dose OAT and high coverage needle and syringe program in combination can reduce an individual's risk of acquiring hepatitis C by 80%. So we have this good evidence that combination harm reduction is effective at preventing hepatitis C transmission. There's other systematic review evidence to indicate that these harm reduction interventions are highly effective at preventing HIV transmission. And we have had recent HIV outbreaks, particularly in rural and suburban areas in the United States, areas where they've seen the most rapid expansion of injection drug use lately. as well as very, very high risk of overdose. So these expansion harm reduction programs could both help achieve hepatitis C elimination as well as reducing HIV and reducing the risk of fatal overdose. There's very strong evidence that opiate agonist therapy reduces the risk of overdose. Okay, but despite this strong evidence, unfortunately, in the United States, coverage is far from adequate. This is new systematic review data by Louisa Degenhardt and her team at New South Wales, UNSW, that just came out this year, that updated their global estimates of harm reduction coverage. I know this, I'm not sure how large this screen is for you, but it's probably a little bit too hard to read. But on the x-axis is the number of OAT recipients per 100 PWID. The y-axis is the number of needle and syringes distributed per PWID. And the dotted lines here on the right-hand side and on the top indicate sort of the threshold levels for achieving moderate coverage of OAT and needle and syringe programs. And what you can hopefully see is that in this top right-hand quadrant, there's only a tiny handful of countries that are achieving both high coverage of needle and syringe programs and opiate agonist therapy, Australia being one of them, and I'll get back to that in a moment. But other than that, really only a few countries that representing sort of only a couple % of the global PWID population that living in countries that have adequate coverage of both of these harm reduction interventions. In the US, we're right here in the middle, but below both of these coverage, recommended coverage guidelines, where here in the US, we have less than 20 opiate agonist therapy recipients per 100 PWID, less than 30 syringes distributed per PWID per year, completely inadequate coverage that needs to be scaled up in order to make any meaningful impact on these syndemics that I've been mentioning. Okay, I'll get back to some other implications of things that we need in the US in a moment, but I'd like to shift a little bit to some work that we're doing looking at hepatitis C elimination among people who inject drugs in Tijuana, Mexico, because there are many parallels in terms of the situation in the US as well as in Mexico. So I'm particularly interested in Mexico because it's a country that's adjacent to the US, but also because I reside here in San Diego, California, which is on the very southwestern border of the United States, and it is contiguous with a city called Tijuana. So the San Diego-Tijuana border region is just a contiguous city from downtown San Diego. It just takes 20 minutes to get across the border. And we have many longstanding research studies that have been focused on the US-Mexico border region that I have had the privilege to be involved in. Mexico was among the first Latin American countries committed to hepatitis C elimination. And so that was actually very promising. They started discussing and funding allocating small amounts of funding towards hepatitis C treatment prior to the COVID-19 pandemic. Unfortunately, some of that has stalled a little bit since the COVID-19 pandemic, and I'll get back to that in a moment. But they were really one of the first countries in Latin America to have a national plan committed to hepatitis C elimination. As I mentioned, we've focused quite a lot of energy studying the Tijuana, Mexico border region. It's situated on a major drug trafficking route of drugs from Mexico into the United States. There's an estimated about 10,000 people who inject drugs in Tijuana. There's a very high burden of hepatitis C among people who inject drugs there, estimated over 90% with a history of hepatitis C infection and a high incidence of hepatitis C as well. So some work that my PhD student, Laura Marquez, did as a PhD student and as a postdoc was to develop some modeling to estimate what is needed for hepatitis C elimination among people who inject drugs in Tijuana, Mexico. And so she developed a dynamic model of hepatitis C transmission, calibrated it to some of the data that I mentioned, and looked at the level of treatment that would be required to achieve both the incidence and the mortality elimination goals. And I'll focus on this incidence goal right now. She showed that if the treatments were prioritized to current people who inject drugs, that about 800 treatments per year would be required in Tijuana among people who inject drugs if the treatment was scaled up in 2019, which is when the initiative should have started. And what she also showed, which was similar to many, many other modeling studies that have looked at this, is that if you increase coverage of harm reduction at the same time as you expand treatment, it actually reduces the number of treatments that you need to achieve elimination, because you're both reducing primary incidence directly through harm reduction, as well as reducing the risk of reinfection after an individual is treated. And so these shaded boxes here just show you that as you increase coverage of harm reduction, from 28% coverage of people who inject drugs, 40% and 60% coverage, it reduces the number of treatments that are required to achieve those elimination targets. And so if that were to happen, then that would reduce the number of treatments that were needed for people who inject drugs to reach the elimination target from about 800 to just under 500 treatments a year for people who inject drugs. Now, what we wanted to know was how has progress, what has been the progress since the COVID-19 pandemic? And so we've worked with our colleagues in the border region to try to understand how much treatment and testing has been going on. I can say that testing has continued during the COVID-19 pandemic. However, treatment has remained very limited. So in 2022, we know that there were 361 non-incarcerated persons treated in Tijuana. It's unknown exactly how many of those were people who inject drugs, but it's likely low. So Stephanie Strafty, who is a professor at UC San Diego, has a binational cohort of people who inject drugs, both in Tijuana as well as in San Diego. And among her cohort, none reported receiving hepatitis C treatment as in 2021. And so it does seem like there's still some substantial gaps in terms of treatment access for people who inject drugs specifically. Even if all of those 361 treatments had gone to people who inject drugs, the current treatment rates would still be insufficient to achieve elimination. So it's pretty clear that there's still a gap between where we need to be in order to achieve our elimination targets. But there is some treatment going on. So what is needed in Mexico? I think what's needed in Mexico is actually very much what's needed in the US, in particular in rural areas. We need to bring services to where people who inject drugs actually are. So when treatment services started in Tijuana, again, this is the US-Mexico border. This red star is where most of the people who inject drugs reside. And when treatment started to become available, it was only available at one clinic here in the red on the right-hand side of this picture, which was about 15 miles away from where most people who inject drugs lived, and about 90 minutes by bus. So it was just prohibitively too far. And we know it was too far because it's the same clinic that provides the majority of HIV treatment in Tijuana, and we still have less than 10% of HIV-infected people who inject drugs that are accessing ART. And they report this location really being the major barrier to accessing HIV treatment, which is free under the national health system in Mexico. Sorry, I should also mention that the hepatitis C treatment is free as well. So treatment cost is not a barrier. It really is these more structural barriers that we're talking about. More recently, they've expanded treatment a bit into the community. It's now additionally available at 5 health centers. And so we're hoping that this will result in increased treatment uptake. And in addition to sort of pushing treatment out into the community where people live, harm reduction access remains extremely limited and is a key barrier to hepatitis C elimination in Mexico. So really sadly, the current president of Mexico, President López Obrador, has shown very little support for harm reduction since he's come into office, cutting funding since taking office in 2018. There is a huge methadone shortage across Mexico. The only methadone production plant was closed earlier this year. And as you can see, this was actually picked up in Vice News back in April, which was reporting on the closure of this plant. And it has substantial ramifications in terms of both hepatitis C as well as opioid overdose in Mexico. It's a critical issue. As well as limitations to OAT access, syringe service program provision has also been substantially curtailed since 2015. So prior to 2015, the Global Fund was actually funding the majority of all the syringe service programs in Mexico. In 2015, Mexico was reclassified as an upper middle income country, and the Global Fund withdrew funding. And since then, funding for syringe service programs has been extremely limited. In our cohort of people who inject drugs in Tijuana, they report receiving on average just 3 syringes per person in the past 6 months, a total of 3. So you can see that the level of coverage is wholly inadequate. There are also several other barriers to both hepatitis C as well as HIV care that have been reported in this region. A need for cultural competency in addressing sort of injection drug use and hepatitis C, intersectional stigmas in terms of those overlapping stigmas that really need more consideration and care, and the healthcare professionals that are working with these populations. In Mexico, and in particular in Tijuana, we see a lot of police interference, both in terms of access of harm reduction services, access of any kind of sort of healthcare services. There's a lot of police harassment, which our previous research is associated with receptive syringe sharing and practices which can fuel hepatitis C. And so there are actually a number of studies that our research teams and colleagues have done looking at working with the police to reduce harassment and have the police take more of a public health sort of approach to policing. I don't have time to talk about those today, but I'm very happy to talk about them if we have time in the Q&A. And unstable housing remains a substantial consideration in terms of people who inject drugs, both access to care as well as hepatitis C risk, both in Tijuana as well as in other settings in the United States as well. And in fact, in the US as well as in Mexico, we have continued police sweeps in some settings where individuals are either arrested or forcibly displaced who are unstably housed. And there's been some very nice modeling work done that has actually looked at the potential impact of that on negative health outcomes among people who inject drugs. Okay, so opportunities and needs, I think both in the US and Mexico, we definitely need to scale up diagnosis. Point of care testing, I think, will be critical of this. I mentioned the need to continually decentralize care. Some of this has been done a little bit with the COVID pandemic in terms of mobile vans and telehealth. And I hope that will continue and expand in the coming years. There's a high perceived need and acceptability of peer navigators, which I think could address the broader health needs of people who inject drugs and provide sort of holistic care. And we definitely still need continued advocacy for harm reduction across both countries and scaling up these services because current coverage is inadequate. Now, slightly more positively, I'd like to shift to some of the modeling work that we're doing looking at hepatitis C elimination among people who inject drugs in Australia. And so as many of you are probably aware, there's the annual Australian Needle and Syringe Program survey, and that survey has monitored annually this sort of uptake of treatment as well as chronic hepatitis C prevalence among people who inject drugs in that survey. And what you can see is that from 2015, there was a very dramatic increase until 2019 in terms of the proportion of people who inject drugs who have ever initiated hepatitis C treatment. So starting at about 10% in 2015, increasing to about 55% by 2019. That proportion has stabilized a little bit. It's a little hard to interpret these 2020 and 2021 years because only a subset of individuals were reported, a subset of sites were reported in those surveys. But if you look at sort of the trend from 2019 to 2022, you can see that although there may still be increases in the proportion who have initiated treatment, it has stabilized somewhat, or the rate of increase has slowed somewhat over the last few years. In tandem, there have been dramatic declines in chronic RNA prevalence among people who inject drugs from about 45% in 2015 to just over 10% in 2022. So really dramatic and encouraging evidence that these increasing in treatment rates could be associated with declines in both chronic hepatitis C prevalence, and then you would anticipate similar declines in hepatitis C incidence. What makes this a little bit of an interesting modeling question is that we also have changing demographics of the PWID population in the needle and syringe program survey data. So here, what I'm showing you is the median age, which are the blue dots, and the median years since first injection, which are the orange dots in this slide, showing a really consistent and stable trend towards an older PWID population that has been injecting for longer, really an aging population. And so we would anticipate that these changing demographics would also have an effect in terms of hepatitis C transmission and incidence. And so what we wanted to do was use modeling to understand these trends and how these trends could impact hepatitis C elimination and transmission in the future. So the key questions that we had for the modeling work that we've done is to first look at how much of the recent prevalence declines among people who inject drugs could be attributable to treatment compared to just changing demography, et cetera. And given the sort of slowing of treatment uptake, is Australia still on track to reach the elimination targets among people who inject drugs? So this is work that has been done by Antoine Chillon at UCSD and Lisa Mayer and others at the Kirby. It's ongoing work, so it's not yet finished, but this is where we are right now. We've developed a dynamic transmission model of hepatitis C among people who inject drugs. It includes some heterogeneity, both in the duration of injecting as well as OAT status and differences in treatment uptake by these characteristics based on data from Australia. We calibrate this model to this nice Australian Needle and Syringe Program survey data in terms of the proportion of people who inject drugs with a history of hepatitis C treatment each year, hepatitis C antibody prevalence each year, estimates of spontaneous clearance, OST uptake, PWID population size, and the distribution by the duration of injection, as well as some trends, historic trends and incidence declines that were observed using the Needle and Syringe Program survey data among a subsample of participants who were repeat attenders. And so when we put this all into a model, what we want to do is we run two different scenarios. The first scenario is the question is to assess what extent the declines in chronic prevalence could be attributed to treatment scale up. And so for that, we compare our calibrated model projections of chronic hepatitis C among people who inject drugs to the ANSPS data from 2015 to 2022. And then we compare that calibrated model projections to a counterfactual of no treatment scale up after 2015. And then in order to assess whether Australia is on track for hepatitis C elimination, we compare incidence projections in 2013 compared to 2015. And here's what we found. This is just to show you some of the model calibration. This is the PWID demography. This is the left-hand side figure here is the proportion of people who inject drugs who've been injecting less than 3 years. You can see that's declined quite substantially over time, while the proportion of people who inject drugs who have been injecting over 30 years has increased over time. So the model calibrating to those fits. Additionally, the model calibrates well to these increases in the proportion ever treated among treatment eligible, which is shown here. And the hepatitis C antibody prevalence trends generally captured fairly well by the model. You can see here the data in red, the model in black with the gray showing our confidence intervals. There has been a sort of marked decline. The very last data point here in terms of antibody was quite low, and we're still trying to understand these dynamics, but generally speaking, capturing these trends pretty well. All right, so what does the model project? So using this sort of treatment uptake, the model projects that chronic hepatitis C prevalence has likely declined substantially since treatment scale up in 2015. And we were encouraged because the model projections of chronic hepatitis C prevalence declines among people who inject drugs matched the data quite well. And I'm sorry that these are in gray. They should really be in a color that you can see better. But the data here in terms of the ANSP survey data is here in these dashes, in these gray sort of horizontal lines. And you can see that the model trends really going through and projecting consistent and validated against those trends. Again, we did not calibrate to these data. This is data that the model is generating just based on calibrating to treatment uptake and projecting the declines in chronic prevalence. So we can see that there's a consistency in what the model is projecting and what the survey is observing in terms of chronic prevalence. Then we can use the model to project what the chronic prevalence would have been without treatment scale up. And that's shown here in the purple with less dramatic declines projected in chronic prevalence, although we still projected that there would be some declines in prevalence due to both demographic change as well as historic levels of treatment prior to the dramatic scale up in 2015. And overall, the model predicts that an 80% reduction in incidence among people who inject drugs in Australia is likely to be achieved by 2025. And this work complements several other modeling studies that are ongoing in Australia, and I'll just highlight one of them. This is work that Jack Stone and Peter Vickerman's team at the University of Bristol led, and it was looking at hepatitis C elimination in New South Wales, Australia specifically. And this piece of work was actually looking at the contribution of prison-based treatment to hepatitis C elimination. And so this model was used to estimate both the contribution of incarceration to hepatitis C infection. In this model, showing that incarceration will likely contribute to just under a quarter of new hepatitis C infections from 2020 to 2029. So really a substantial contribution of incarceration to hepatitis C transmission. But very promisingly, if the prison-based interventions had not been implemented since 2010, hepatitis C incidence would have been 30% higher than it is in 2020. And that if current prison and community hepatitis C treatment rates continued, their modeling work showing a 99% probability that the elimination targets would be achieved in New South Wales, Australia by 2030. With that decreasing to only 10% probability that elimination would be achieved without current prison-based interventions. So I think these modeling work, the modeling work is sort of complementary in showing that Australia is very likely on track to reach the hepatitis C incidence elimination goals, both broadly as well as in specific settings. And this work, I think, really nicely illustrating the substantial contribution of prison-based interventions to achieving hepatitis C elimination, which I think is very important work for the rest of the world and in the US in particular, to kind of emphasize the importance of treatment and correction settings on broader elimination initiatives. And so finally, in my last minute, just to recap, I think there's highly heterogeneous progress towards reducing hepatitis C incidence. I've shown very promising progress in Australia. We need more substantial efforts in the US and Canada. I think modeling is been very helpful at different stages of elimination programs in terms of its utility. So in the US, we're at the early stages of this and just trying to use the modeling to understand what level of scale up and interventions do we need in order to achieve elimination. Oh, sorry, this is US and Canada. I meant to say US and Mexico. In Mexico, where we are is sort of using the modeling to gauge whether we are achieving the targets that the modeling predicted we needed in order to achieve hepatitis C elimination. Clearly not there yet and need further scale up in terms of treatment and harm reduction efforts. In Australia, we're a bit further along where we're trying to use the modeling to disentangle these different complexities in terms of changing demography and understand the impact of different treatment initiatives, both in prison as well as in the community. And so that's a very exciting use of modeling as well. In most settings, just to underscore, there's a dramatic need for harm reduction scale up. We need to remove access barriers to opiate agonist therapy. In some settings, there were encouraging steps made during the COVID-19 pandemic to remove some of those barriers, in particular in the United States. We had a few initiatives, but there are still too many barriers, and we still need to broaden access to both opiate agonist therapy as well as needle and syringe programs. And in general, I think really using the innovative work that's been done in Australia and some other settings in Europe to think about how we can simplify and enable healthcare access. Of course, point of care testing initiatives being critical in the US, need to get those approved and broadly into the community. Community settings for treatment and testing in terms of mobile vans, pharmacies, thinking about these one-stop shops for integrated care, not just for hepatitis C, but other substance use issues, I think is critical. Peer navigators, I mentioned, as being an important component of the strategy, and hepatitis C testing and treatment, as well as harm reduction in correction settings. So thank you again very much for having me. And I will just mention that I have the great privilege to be the Vice President of the International Network on Health and Hepatitis and Substance Users, or INSU. Our fearless leader, Jason Grevely, is the president, and we encourage anyone who is not already planning to attend to come to our conference. This year, our conference will be in October in Geneva, Switzerland, and a lot of more exciting modeling and hepatitis C elimination work will be presented there. So hope to see you in person in Geneva. Thanks again.
Thanks, Natasha, for a fabulous presentation. Very sobering to hear the data from the United States and Mexico. You can hear me okay? Yep. I might start with a couple of questions, one relating to the United States and one for us here in Australia. Firstly, the $13 billion commitment is very welcome, clearly. I mean, I'm being concerned about how much of that money will end up in pharmaceutical company and diagnostic companies sort of pockets without a significant contribution going to scale up of harm reduction. Do you think there's any possibility of some of that money going to federal government support for needle and syringe programs in the US?
I would love to say that I'm optimistic about it. I'm not sure. I mean, there's very big question marks in terms of how that money will be allocated, what the mechanisms will be in terms of distributing that money, who's going to get it, whether there will be funding set aside for more research-based opportunities to kind of look at these innovations, whether it be more, direct funding in terms of programs. In terms of your direct question about harm reduction, we obviously still have substantial political barriers. Many states actually, it's still illegal to actually provide direct funding for needle and syringe programs. And so that remains a substantial barrier. And I think that there are certainly areas where we see some promising progress in terms of expanding access, San Diego being one of them. So whereas for many decades, San Diego, actually, it was illegal to fund needle and syringe programs. For the in the last 2 years, they've actually reversed that. And there is finally funding in my city for it. But the pace of progress is extremely slow, and I'm not particularly optimistic that this money will go towards programs like that, but we'll have to see.
Second question related to Australia, and I hadn't seen the 2022 Hep C RNA prevalence data point, so that's incredibly encouraging. Looks like it's 12%, down from 16 in 2020 and 2021. What you presented was our capacity to reach a relative reduction in incidence by 80% compared to 2015. Have you also looked at what the absolute incidence among the population of people who inject drugs will be, given the WHO new targets of less than 2 per 100 person years?
Yeah, that's a great question. It's something that we're looking at. So we have actually looked at it. We are still trying to refine the modeling, but at the moment, it is estimating that the absolute incidence would be below that 2 per 100 person years WHO threshold. In fact, some of the modeling that we're doing is indicating that it might already be there that low. I know, and I didn't actually have time to present. I know that there has been some more recent work looking at that subsample of ANSPS repeat attendance that have shown that incidence has declined, I think, by about 58% from 2010 to 2015 and 2016 to 2021 between those two time periods. And so among that subsample, we see a dramatic decline. And I think the most recent estimate, oh, maybe you can remind me, Greg, was about 5 per 100 person years for that group. Now, it's hard to know how generalizable that particular group is to the broader PWID population. Again, those are repeat attendance. It's a subsample. But I think it is possible that Australia is near that, both that absolute threshold as well as that relative reduction.
Yeah, the figure was, I think it came down from 1,300 person years pre-DAA to 5 in the DAA era. That was primary infection incidence. It wasn't combined primary and reinfection. I think we've got a couple of questions online. First from John Didlick, interested to hear any comments you can offer about modelling spontaneous clearance, or what sort of parameter estimate do you include within your models in the US-based modelling work?
Yeah, so we don't have much HIV co-infection in the United States, and so we tend to just use the sort of standard estimate of about 25% of individuals spontaneously cleared, and we do vary that in the models. For the Australian data, we actually use the data directly from the needle and syringe survey, which is sort of in that range, although slightly lower, I believe.
Okay, next question from Craig. How important is good quality surveillance information about testing, risk behaviours, treatment uptake, clearance, genotypes, and reinfection for modelling estimates now and going forward?
Yeah, thanks for that question. So good surveillance is critical. And I think that the Australia work that we showed, I hope, shows you how much more nuanced the modeling and the insights can be when you have good quality surveillance. So the surveillance and the modeling really can work hand in hand in trying to help us understand the complexities in terms of the changing demographics and treatment scale up, and really understanding whether what we're seeing in terms of declines are consistent with what the modeling might predict in terms of treatment as prevention benefit. And especially in settings where you have potentially scale up of other interventions like harm reduction, as well as treatment and changing demography, the modeling can really be used to understand that, as well as to understand which subpopulations may be left behind. And I think that's going to be increasingly critical as we move towards elimination and we're able to treat, the people who are in care, et cetera, or the sort of more closely aligned with the health system, and we start getting to the situation where we need to reach individuals who have not yet been served well by our health system. And that's where good quality surveillance data, I think, will be really important in terms of understanding, for example, unstable housing, or in the correction setting, where are we missing individuals and how can we best identify them?
We'll go to a question from here in the room from Andrew Lloyd.
G'day, Natasha. Thanks so much for the talk. I'm struck by that discordance between the relatively young, relatively new onset injecting drug use people who are incarcerated, and the older, long-standing injecting population in the needle and syringe program. So my sense is they are polar ends of the Australian PWID population. So I'm just wondering about your thoughts about generalizability to the whole of the Australian PWID population for both of those likely extremes.
Thanks, Andrew. Sorry, can you just generalizability of what exactly?
Generalizability about incidence reduction. Are we going to get there? Because if we rest on our laurels of the needle and syringe program data, it's likely there are other subpopulations that aren't quite so good.
Yeah. Understand. Okay. Yes. So I think that I understand, if I understand what you're saying, that we sort of see one snapshot in the needle and syringe survey data, and we see another snapshot in prisons. And I guess what you're saying is if those two, if we're not continuing our efforts in both of those arenas, would that compromise hepatitis C elimination? And I think that you're absolutely right. So when I was sort of highlighting the work in New South Wales, of course, there's been the Stop C program and a substantial increase in scale up of treatment in the New South Wales prisons. And so you're absolutely right that that doesn't necessarily translate to a national estimate. We would need to basically replicate the Stop C program across Australia to ensure that the gains that are observed in New South Wales are sort of observed nationally, if that's what I understand of your question.
I think there's also been the notion that the NSP survey may not be representative. So it may be a group of people that are repeat sort of participants in the survey. They're an aging cohort, sort of leaves out maybe some younger, more stimulant injecting sectors of the population. So I think that's why the prison surveillance data is really crucial to see whether we're getting similar reductions in RNA sort of prevalence sort of going forward. There's another question relating to stimulants from Richard Kemp online. Interested to hear about your thinking of the impact of meth injection, for which there are currently no substitution programs.
Yeah, I think it's a great point, and thank you very much for bringing it up. We have the same concern in the United States, where there's an increasing proportion of overdoses due to associated with stimulant use. And so we know that that is an increasing problem in the US. Of course, methamphetamine use has sort of consistently been quite prevalent in Australia. And so we absolutely need to continue to think of interventions to address that from a broader PWID health perspective. But on the other hand, at least the data that we saw in Australia, I think there's still there's no disparity in hepatitis C treatment uptake between those populations. That was the last data that I saw. I haven't looked at the most recent years survey data, but at least in previous years, there was similar hepatitis C treatment uptake in that group. And so if we can continue to provide them access to treatment and syringe services, that will help, but we need more harm reduction initiatives.
And Natasha, just one more question going back to the strain model. It looked like in terms of the chronic hep C prevalence that by 2030 it was around about the 10% sort of mark, I think, in the model. So we're almost sort of there now. I mean, that's just one data point in 2022. So in some senses, it might even be a little conservative if we can keep sort of pushing and get that RNA prevalence down below 5% over the coming sort of 4 or 5 years. And that would even drive, obviously, incidence of primary and reinfection down more rapidly.
Yeah, agreed.
So look, thanks so much, Natasha. It's been great to hear your insights, and it's just really valuable to get that contrasting situation in the United States, in Mexico and Australia presented in such an accessible format. So thanks very much for joining us for World Hepatitis Day. Thanks.
Thanks again for having me.